think you'd all agree we'll allow Dr. Tedros to get online and proceed thereafter, okay? So we'll just give a few minutes. That thumbs up is confirming that he's online. Wonderful. Greetings from Lake Bled, Dr. Tedros. You're here with several colleagues. Allow me to simply welcome you to this specific session at the Bled Strategic Forum on sustaining peace in a fragmented world, but specifically looking at the promotion of peace-responsive health interventions. We will hear from a distinguished panel, and before doing so, allow me to welcome the Director General of the World Health Organization, Dr. Tedros, who is with us online. I hope you can hear and see us, sir.
Yes.
Wonderful, and we hear you loud and clear. Before turning to you, sir, I just would state that we're convening this session at a moment where we understand that the increased level of conflicts within and between states is having a disastrous impact on the broader health sector. And we also commend the great leadership by the World Health Organization and its member states in the advancement of the broader global health and peace initiative. Before turning and introducing the panel, allow me, Sir Dr. Tedros, to welcome you for opening remarks. We very much look forward to your physical presence. However, your virtual presence is very well received, and we look forward to hearing from you now. The floor is yours, sir, and we will invite others to join thereafter. Dr. Tedros.
Thank you so much, moderator. Apologize, I couldn't be with you in Slovenia. I just came actually from a meeting briefing our Sherpa, the committee that follows emergency preparedness and response in WHO, briefing them about Mpox, the current situation and what we're doing. I just recently came back from Kinshasa last Friday, actually. So I was briefing our member states there, the committee and member states. So that's why I was a bit late, so I'm really sorry for that. And Your Excellency, Deputy Prime Minister Tanya Fajan, Excellencies, dear colleagues and friends, good afternoon and thank you for the opportunity to join you virtually. And thank you for accommodating me. I'm sorry I'm not able to be with you in person as I had actually originally planned if it wasn't for Mpox. But thank you for accommodating me from Geneva, and thank you for convening this important discussion on health and peace. This is a growing area of WHO's work. In 2019, we launched the WHO Global Health and Peace Initiative with the support of Oman and Switzerland. This year, the World Health Assembly adopted a resolution supporting the initiative, and I thank the government of Slovenia for its support for that resolution. Peace and health are inextricably linked, and both are under attack. The crisis in Gaza, Sudan, and Ukraine illustrate how armed conflict destroys health systems, disrupts supply chains, and damages the health workforce, and can lead to outbreaks of polio, cholera, measles, and even Mpox. About 70% of disease outbreaks that WHO responds to take place in fragile and conflict-affected situations. Even the last frontiers of polio are Afghanistan and Pakistan, and it's the insecurity and instability that's helping the virus. In Gaza, the conflict has led to the first case of polio in 25 years. While in the Democratic Republic of the Congo, a new strain of Mpox is spreading in the eastern provinces of North and South Kivu, which have suffered decades of insecurity. Where conflicts goes, disease follows. Conflict increases the demand on the health system, but it also often reduces the health system's capacity to respond to that demand. In recent years, we have also seen a growing trend of attacks on healthcare. And so far this year, WHO has verified 757 attacks on healthcare in 13 countries, causing more than 400 deaths and almost 700 injuries. Attacks on healthcare are a violation of international humanitarian law and deprive people of life-saving health services at the time they need them most. In Gaza, Sudan, Ukraine, and elsewhere, WHO is working to support the health system and deliver health services. But ultimately, the best medicine in each of these situations is peace. There can be no health without peace. But equally, there can be no peace without health. The authors of the WHO Constitution knew this when they wrote that the health of all people is fundamental to the attainment of peace and security and is dependent on the fullest cooperation of individuals and states. In post-conflict settings, reconstruction efforts can advance peace and health outcomes simultaneously. Rebuilding health systems and restoring essential services with a focus on equity can help to build trust and confidence. Health can also be an opportunity to reopen dialogue between divided groups and citizens and health authorities. Other examples of how health interventions can support peace building includes joint disease surveillance programs or joint training of the healthcare workforce across conflict lines. Mental health and psychosocial support also plays a vital role in post-conflict reconstruction. By supporting social stability, improving gender equity, reducing stigma, and helping to repair relationships. Examples of how inclusive mental health and psychosocial support services by WHO and our partners have contributed to peace building in communities include Somalia, Sri Lanka, and Burkina Faso. Health programs implemented in a peace-responsive way also offer significant benefits to women, girls, and other marginalized populations. For example, in Haiti, WHO, UN Women, and their partners are working to reduce community violence by enhancing young women's leadership through dialogue by supporting psychosocial recovery and resilience. By empowering young women to become agents of peace that can contribute to strengthening local health systems and governance, we contribute to laying the groundwork for lasting peace and stability. Let me leave you with two concluding thoughts. First, we should recognize health as a peace-building priority and promote integrated multi-sectoral approaches that enhance the social contract and human security. The Secretary General's new agenda for peace calls upon national governments to contribute to conflict prevention and sustaining peace. The upcoming 2025 review of the UN peacebuilding architecture presents an opportunity to strengthen the health sector's role in peacebuilding, including by recognizing WHO's role in supporting member states in their health and peace efforts. Second, we must increase both political and financial support for conflict-sensitive and peace-responsive health programs, recognizing that investments in health and equity can also be investments in peace and vice versa. There cannot be health without peace, and there cannot be peace without health. I thank you, and moderator, back to you.
Thank you, Your Excellency, Dr. Tedros. Very clear and mindful of all the pressing demands upon you. And on behalf of the international community, allow me immediately to turn to Dr. Kerstin Petrič, a member of the Executive Board of the World Health Organization, to express appreciation as well as observations in light of your opening remarks. Dr. Tedros, should your time permit, we welcome your presence, but I understand if that does not allow for the entirety of the session. Dr. Petrič, if you would.
Thank you very much. I don't know really what the question was to me, but definitely I do appreciate not just what Dr. Tedros has said, but his work in the organization. I happened to be fortunate to take part in the EB, which is Executive Board of the WHO organization. I actually was a chair 2 years ago of the executive board. So I worked hand in hand with Dr. Tedros, and he was now presenting to you in this really short time what actually matters when you are speaking of peace and health, health and peace. But it is amazing how much work is actually done unrecognized by this organization. Dr. Tedros said, I had a meeting and I am a bit late. He was late only a few seconds, so it's not a problem at all. But he had a meeting with a group of people that wanted to be informed on everything going on in the world when it comes to crisis. This was actually a request from the countries. As countries, we requested to have some possibility to talk to Dr. Tedros directly, and since other bodies are big and it's very difficult to convene them in a couple of days or even in a day, couple of hours, where something that is threatening health is there and should be understood and shared, we establish a special body for this, and this is where Dr. Tedros was now, because emergencies are going on and going on. And he really took it seriously. He listened to us countries. He understood we wanted to be informed, but he also said, I need advice and support from your side. Of course, the organization is run by him, but the countries are the ones that ask this organization what to be done, not ask, they actually demand from organization what needs to be done. We are there really carefully looking at what the organization and Dr. Tedros is doing, and we have huge demands. And unfortunately, these huge demands are not really backed by huge money. I just want to share with you that when you speak of organizations like WHO, you should know that, for example, WHO is an organization that has a budget as a big hospital in Geneva. So not much money. They are very devoted people, including Dr. Tedros. So we are struggling because money is needed. And that is why Dr. Tedros also mentioned it, but maybe he was not too explicit. No time for him. I can do it instead of you, Dr. Tedros. We are actually having an initiative how to get more money to support countries when they are in trouble with WHO. And I'll be more specific, more concrete later on what actually WHO is doing in the countries that are in crisis. I talk to people from WHO, which are called WRs. These are head of offices in countries, representing in countries WHO, in Israel, in Ukraine, and Russia. So I talk to these people to learn what are the problems, and Gaza, of course, so all sides, to understand what are the challenges for WHO in concrete situations and what really can be done on the ground. And I'll share with you this a little bit later. And once again, we, countries that work, so professionals from health, but also our diplomacies, we do appreciate a lot the work of Dr. Tedros and his team in this perma-crisis, as we call it, when we are confronted not only with war crisis, but also with crisis, as he mentioned, new diseases, old diseases that are spreading, climate change that is affecting health, and many, many other issues.
Thank you, Dr. Petrič, for this further articulation of the priorities that Dr. Tedros has laid out. And in that light, allow me to refer to the Executive Secretary of the African Union's Post-Conflict Reconstruction and Development Center, based in Cairo. Madame Matlho, I welcome your reflections in light of what has been said. There is no health without peace, no peace without health. You are now leading a center specifically looking at the question of post-conflict reconstruction. Where does the health agenda sit in this regard from the lens of the African Union? Please use the mic in front of you.
Okay. Thank you very much, Your Excellency. Also, I want to reiterate what Dr. Tedros has already said. No health without peace and no peace without health. Indeed, as the African Post-Conflict Reconstruction Center, one of the key issues that we are looking at when we talk of peace and health agenda is how do we build the lives and societies that have been affected by conflict. We are aware of the fact that in situations where conflict has hit our region, especially in Africa, normally you find that diseases, generally, they become one of the apex issues that affect our communities. Most importantly is the issue of feminization of health crisis, and it is no exception in post-conflict settings. For example, we have heard from Dr. Tedros the issue of mpox. We have seen with COVID-19 how much women and children became the faces of these diseases. Unfortunately, due to conflict, the infrastructure, accessibility, availability became a challenge in order for the victims to access such services. And for the African perspective, what are we doing? I will give an example of Somalia, where we have seen the African Union mission in Somalia in terms of the medical board, the outreach program in reaching out to the communities through telemedicine as well as mobile clinics, the impact in which it can advance accessibility to such services. We also want to say that investing in research and innovative hubs in ensuring that medicine is also an answer in peace-building initiatives. Maybe before I can conclude on this first question, I want to highlight the fact that when you talk of mental health, psychosocial support, it is also another area that affects communities that are emerging from conflict, and we cannot ignore it. It is also one of the great pillars in the revised African post-conflict reconstruction development policy, and we are here fostering its implementation in full force. Thank you.
Thank you so much for this. Frédéric Deycard, Associate Director of Conflict Resolution at the Carter Center. Share with us, if you would, from your active, on-the-ground engagement, particularly in Mali, if I understand correctly, what peace gains you have witnessed through health interventions.
Yeah, thank you. Our project stems, I'm going to dial back a little bit on why the Carter Center has been working in this nexus of peace and health, because it is in our mission where we do neglected tropical disease eradication and we do peace building. And like many organizations, WHO, INGOs or others, our health programs hit this situation where how do we access areas where conflict or violence is endemic and ongoing. And well, after working for almost 40 years in parallel direction between our health programs and our peace program, we figured that maybe we could work together in order to enhance access to health services and peace building at the same time. In Mali, our initial focus was to try to provide access to Guinea worm eradication programs to central Mali, where the epicenter of the conflict that's been ongoing since 2012 was happening. This is where most violence exists. This is where no hope for peace or peace agreements exist because of the multiplicity of actors and violent actors, being militias, being jihadi groups, being other type of self-defense militia, or even government action versus civilian. So our challenge was to access areas that were essentially controlled by whether militias or jihadi groups, and provide some access to health. And the key to that was not just, as was said before, to advance health in order to build peace, or advance peace in order to build health, but to work together as a comprehensive strategy instead of working in parallel and hoping that enhancing access to health would bring more peace, or peace would bring more health. It was to construct, to build a comprehensive strategy that would put together both the communities at the very local level, the government actors, the health agents, and train them together as mediators, as conflict mitigators, as being able to restore space and time for dialogue and reconstruction, conflict prevention and conflict resolution, and enhancing inclusion to eventually build more access to health.
Thank you for this, Frédéric. I turn to Mariana Beselga, member of the Young Bled Strategic Forum and founder, if I'm not mistaken, and Chief Executive Officer of the Policy Hub for Inclusive Development. You heard your colleague on the panel from the Carter Center referring to inclusive strategies. Could you reflect, please, on the significance of inclusivity and specifically on the impact of conflict on women and girls and what that means for more effective health interventions? Please, if you could use the mic in front of you. Just push the button there.
Thank you. Hello, everyone. When we talk about conflicts and the situation of women and girls, one thing that I want to highlight is the care infrastructure, because with the conflicts, how can I say that, but human are the majority of care providers, and this is affects the care system. So this affects the care system. So how we can improve gender responsive policies in terms of how we can create new economies focused on gender care and gender economy. And when I talk about gender economy, I talk about human is the majority of care providers. I'm quite nervous. This is my first time, guys.
You're doing a great job.
No, I will try to do my best. It's like human are the majority of care providers, and they don't have the support of international organizations. But now with the WPS agenda, we are seeing an improvement in this term. So we are looking to the care infrastructure like something essential to provide peace and in this context. And in terms of inclusive policies, we need to create inclusive budget frameworks. We need to look at the conflict and provide support to the human and girls in terms of investment and in terms of recovery economies. So we need to look to the gender responsive policies and care frameworks. So human are the majority of care providers. They are nurses. They are with the conflict. We can see a care building increase. So it's basically that.
Thank you, Mariana. Very clear. Thank you for this.
Okay.
Dr. Tedros, I see you still online, and we received a message and promised your office that we would be mindful of the time, the pressing times on your schedule. You've heard from a member of the executive board, a representative of the African Union, practitioner from the Carter Center, an organization I know you've known for many years, and from the voice of a young leader who is advancing organizations and leading them, and put forward a very clear argument for the importance of inclusive processes. So I turn to you for a final word before we continue our further discussion. Dr. Tedros.
Yeah, thank you very much. I would like to thank fellow panel members for their intervention, and I agree with their contribution. Maybe if there is one thing that would suffice, I think from what you said, inclusion is really central. And to that I might add and say inclusion, especially strong community ownership and participation. As we say, outbreaks start in communities and also end in communities. And the same with conflicts. And peace, if we talk about peace, then without strong community ownership and participation, it wouldn't happen. And if we say managing outbreaks or stopping outbreaks like the current one, Mpox, without clear community ownership and participation, a very inclusive process, the stopping outbreaks cannot happen. So I think that's very, very central. So in peace building, I think the communities are the most affected, especially women, and without their participation, it cannot happen. I think that's what I picked up from what you said. Of course, not only in responding, but during recovery as well, the same community participation and ownership and inclusive process, and with a focus on the most vulnerable, like women, as what Mariana had said, our young leader, is very, very important. So thank you so much again, and back to you, my brother.
Thank you so much, Dr. Tedros. It is always good to hear you, and we applaud the global leadership you are demonstrating. And as an organization that I lead, the Health and Peace Initiative, we see as part and parcel of advancing the sustaining peace agenda. And we stand ready to partner with those here on the panel, and most especially with the World Health Organization. So we thank you, sir, for your continued leadership in this regard. Dr. Petrič, you mentioned your regular outreach to various representatives in conflict-affected countries. And could you reflect more on the extent to which you hear about the integration of the Health and Peace Initiative in context?
I actually contacted my colleagues that are in the countries that are affected because I wanted to prepare well for this session. And I regret that I didn't do it before, because I got so much insight how difficult it is when there is war and conflict going on to introduce peace as a topic even to the government. The government is obsessed with the war and defense and all other things. So there's a difficulty for the government to discuss health in such circumstances. So WHO role in this is even more important, because they can bring health on the agenda when it is actually possible. So they look for windows of opportunities. And I'll share the story that I heard from the colleague that is working in Israel now. There's no war, but indeed, you know, the country now is in war. So, of course, they are also affected, people there, but it's different than in Gaza or Ukraine, for example, uncomparable. So, when they were, you know, after October the 7th, you know that this attack affected a lot of people also. And there was a huge need. The need for mental health services doubled. actually, in the developed country like Israel, I was told, it was very difficult to get some more resources to support these people in need, and to have health professionals there, mental health professionals in particular, because it was a lot of mental health issues in that area. So there it was where WHO stepped in and offered support until the country, the rich country even, could actually ensure capacities to support people in need, because this cannot wait. People are in need, and we have to deal with this immediately, not after. So what happened through this was that there was a kind of trust built with the organization. So in a country that is, that environment indeed is in a way hostile. I'm speaking of Israel, even towards international organizations. There's a lot of mistrust at the moment. People are confused whom to trust. But with offering and organizing support to those people in need, opened a channel for discussion. So when it came now to the conversation on vaccination of children in Gaza, polio, I'm speaking of polio, indeed, at least we had, or WHO had, a window of a channel of communication with the government there. And there was not mistrust per se. So, you could communicate things, ceasefire, the necessity to actually to have vaccination ready, and we heard today it's a very successful operation in this. And this is important. The same in Ukraine and Russia. There are people in occupied areas that are affected by HIV. They do need medicines. So and they are Ukrainians. So, but they do need access to medicines. So WHO is there to, again, have these channels open to be able to talk to Russians to secure medicine to these people there. It's much more complicated for health. We have indeed to all the time think that nobody can be left behind. And I'm just adding one thing. When the war in Ukraine started, we were thinking a lot of sanctions. And among many things that happened, there was an idea that we will exclude Russia from projects, health projects. One of those looking at school children behavior. So there was a study, and there was agreement in EU to exclude Russia, which to me was horrible. We cannot exclude Russian children from a study because we will then not know for years what is happening to these children. So these things are much more complicated for us in health. We cannot simply take sides, at these geopolitical discussions. We have to really pay attention to people. In a way, it is easier for us, because we don't discuss who's right and who's wrong. We focus on the needs of vulnerable, indeed on most vulnerable, because that is what health people do. And here I will refer also to the fact that was presented here. 70% or more people in health are women. They are the carers, but only 10% of women are in decision-making bodies that discuss health. What about the rest of it? So to give women more possibility to be around the table when decisions are made, maybe will contribute to more peace. And here I really appreciate the initiative of the young colleague here to try to push for this and to have more understanding for the needs of women, but not only for the needs. I would say for potentials of women. Figure it out. 70% of health workers are women. There's a huge potential. So why do we ignore it?
Wow. So these are powerful statistics, and further compounded by, in the conflict space, what we know also to be true, that the majority of individuals impacted by situations of conflict are women and girls. hence the resolution 1325 that takes this more fully to the center. But what I heard you say, Dr. Petrič, on so many levels are compelling, and I hear one that echoes the need or necessity to protect cooperation, science-based, human-centered, international cooperation, even in the midst of geopolitical tensions and divides. And there are lessons for that, as you know better than I. In the height of the Cold War, cooperation carries on at the technical level as a means of sustaining contact and understanding across divisions. Frédéric, I'm looking at you because I know that the Carter Center, now more than 4 decades in establishment, has committed itself to waging peace, fighting disease, and building hope. That's the phrasing. And there's one specific moment that I recall where President Carter himself, brokering the guinea worm ceasefire that sets a kind of confidence building, if you will, for the comprehensive frameworks in Sudan. Can you reflect upon particularly the state of the world we're in? Increased tensions, you heard Dr. Petrič, the way in which cooperation in health, both from an emergency standpoint and a general public health preparedness standpoint, aids in preparedness for confidence building in the advancement of peace. Frédéric.
Yeah, thank you. It's a great reference. The guinea worm ceasefire in Sudan is both a great example of how health can build peace, because the ceasefire was obtained for 6 months, and after the period of 6 months of complete access for health programs, not just guinea worm, but all form of health programs, it was prolonged by the parties without the help of any form of negotiation because of the success of this access. So, you know, leading by example and showing how health is a fantastic bridge for peace. It's a universal goal for all parties, even warring parties, even everybody needs access to health, right? At the same time, it was a humanitarian type of ceasefire between 2 well-identified belligerents, and it's not necessarily what is a reflection of the state of conflicts today. We often face a situation within countries with multilateral actors. Some are engaged in peace conversations, some are not even solicitated for peace conversations. So how do you do that in a world where conflicts are probably more complex, more protracted, prolonged sometimes in long-term areas, in gray areas with lower intensity conflict, but still there and no access. In the state of the world today, what we've seen in Mali and elsewhere, but in Mali in particular, I can talk about that, is when you engage people who have felt abandoned by their government, who are subjected to daily violence, who are subjected to contradictory injunction for all belligerent parties because they were always suspected to be on one side or the other and end up being the first victims, civilians, of the conflict. If you're able to reach out with the common denominator of health and health access and reaching out to parts of development that can be interested in, you can spark a dialogue. You can spark a conversation, even a conversation and a dialogue that was interrupted for decades. In Mali, government actors didn't have any more access in central Mali, in most of the places, and particularly where we worked. And when we started to conversations with the communities and leveraging their own interests in participating and being co-actors of their own health and own peace, this is where things changed. And I think that's a key word. Community level engagement is important. It's also important not to descend to this level, but to listen to this level and have people tell you and build what they want to build in terms of access to health, in terms of type of intervention they wish. And when you do that, after a year of intervention in Mali, we saw a decrease of 90% of violent events against health factors. We currently have, our initial goal was to have 1 week of full access. We have had access for years now. In every health areas where we work, government agents, not only for health, but also other type of agents, have full access whenever the network we put together, a Peace Through Health network, is working. So it works. It does work when you engage the communities, when you give them some hope, and when you let them co-build their future, you have results in peace and in health access.
Frédéric, this is an excellent example of a set of examples, and I think it builds very well off of what you described, Dr. Petrič, and specifically this language of shared interest and the ability to sustain presence. You referred back to the 6-month agreement on the Guinea Worm ceasefire, which sustained longer. The 1-week request for access, which has carried on. This is the ability to then understand that health is something that is not exclusive, even if you are at odds with someone who you're fighting. It's a shared interest. Dr. Tedros, I see you still online with us, for which we are grateful, and I want to come back to you asking first a question, if you allow me, to the Executive Secretary of the AU's Post-Conflict Reconstruction Center. You referred to the question of mental health and the impact of conflict on the mental health of individuals and communities, if not states. Before going there, I want to zero in on the first part of the center's name, post-conflict. What we see now is a level of catastrophe in the use of force as a means to resolve difference and the deliberate targeting of infrastructure, including health facilities. What does that look like from the African Union's perspective as we advance a post-conflict reconstruction agenda? How do you begin to prioritize, say, in a context like Sudan, which we've reflected on, when you have a capital that is completely decimated, including its health infrastructure? Where do you start with that advocacy, please?
Thank you very much, Your Excellency. I think, first of all, in the name, it's very difficult to draw the line to say we have reached a post-conflict stage, because when you look at trends of conflict, it is normally a vicious cycle from one form of conflict to another. Even at a stage where we may think that we have reached the post, you find that there are those instances where we relapse into conflict. So to answer your question directly, maybe the case of Sudan. Earlier on, I spoke about the issue of investing in infrastructure. Unfortunately, during conflict, you find that social services, they are direct targets for the parties in conflict. Yet, right to health, as Dr. has said, is not seen as a priority. Yet, it is also a human right which needs to be realized. Unfortunately, when you look from the perspective of Post-Conflict Reconstruction Development Center, our main issue is when you are looking at the phases of conflict generally, services of medical or health services, you find that you cannot even access them because they are not available. Issues of medical health providers, they are also not protected because they are also agents of war. They are targeted. For instance, in Africa, on the 31st of August, we were celebrating or commemorating the African traditional medicine there. So these are some of the possibilities or opportunities that as Africans, we can say these are our identities that can give us comfort during conflict or at post-conflict stage. Why am I saying this or bringing this into discussion? It is because at the moment, when you look as of 2023, at least 25% or 25 countries in Africa had already started building or incorporating traditional medicine into health sciences. It also has to do with coming up with policies that regulate these traditional medicines, because they can have dire consequences. At the same time, they can be dangerous to the people. So I think for me, what is very interesting is that there are opportunistic health dangers during conflict and at post-conflict. For instance, gender-based violence from our panelists. Gender-based violence, you find that women and young girls, they become the victims, such as unplanned pregnancies, opportunistic diseases like STDIs, and they are not able to access those services. Where do they go to during this crisis? That is where now they resort to traditional medicines. Hence why we need, as the African Union post-conflict, now to invest and ensure that they are regulated. They are also researched so that they can provide evidence in terms of their triple opportunities and benefits to the affected communities. Thank you.
Thank you so much. Dr. Tedros is offline, so we continue. And he stayed much longer than I had anticipated, which is excellent. Mariana, I was going to ask Dr. Tedros a question, so I ask you now. Is that okay? You had nerves, now you have more. It's good, it's less, good, yeah. Good. So here's my question to you. So we've heard a lot of statistics. And there's a set of statistics that keep me up at night, literally. One of which is that we are experiencing the highest number of conflicts since the end of the Second World War. And conflicts, that is, within states and between states. And it's coupled by a further statistic around the nature of war at present. They are lasting longer and they are more destructive. That has everything to do with the non-adherence also to international law, requiring or enabling them to be more destructive. From the perspective of a young leader here, what does that mean to you? And more specifically, what's your point of advocacy as Slovenia itself now sits, if I'm not mistaken, as the president of the Security Council at a moment of the General Assembly, at a moment of the Summit for the Future? What's the message to the world here from Bled that you would wish to convey in light of those harsh facts?
First of all, I would like to ask a question for the participants. It's like a polemic question, because we don't talk about Yemen. When I look to the statistics of WPS index from Georgetown, Yemen is always in the last position. It's not a country actually safe for human. So because we don't talk about Yemen and the health situation in Yemen, because in terms of reproductive health, it's really worse. We have a type of, it's not a pandemic, but what's the name? It's not a pandemic. It's like an increase of
epidemic? No.
It's not a pandemic. The problem with the water.
Okay.
And new diseases there, and yes, but I would like to ask about Yemen, because we don't talk about Yemen, and my message is, with my background in international relations, we can see in 90s an increase of interstate wars, and in this decade, we can see again an increase of interstate wars. But where is the international community? Because we don't talk about interventions, because we don't talk about policies, because we don't talk about how we can improve the participation of women and decision-making spaces, why we don't talk about data infrastructure to monitoring conflicts, to monitoring policies. I think the international community needs to be more aware and needs to be like an open space for young voices, for minorities. And I think we need to look to the new wars. It's like a Mary Calder approach, but it's beyond on this. We need to create new policies. We need to be more inclusive. And that's it. I would like to talk more about Yemen. I want to see your opinion about Yemen because it's something really horrible. I had a conversation with Nadia Al-Sakab. She was the head of communications of Yemen, and she told us a lot of things about gender-based violence in Yemen, and gender-based violence is a health issue, and I want to know more about your opinions in this case.
Thank you, Mariana. I think what you allude to in so many ways is something that the international health community has identified, and maybe not to the extent desirable, but has invested in, namely in terms of those diseases that are neglected. There's a whole field of thought around neglected tropical diseases. What's missing in the space of conflict is the same level of specialization, intensity, and readiness to accompany conflicts that are not catching the news every day. Yemen stands out in that regard, despite the atrocities, including to infrastructure as you described. If you allow, colleagues, I would wish to open up to those who are in the room, should there be any observations. Please, if you would, sir. Speak freely. Leo, why don't you help us out here?
And I remember, it's cholera. I remember now, cholera. Heart disease, yeah.
Thank you very much. I also have an observation / a question for the panel. A lot of times when we have conflicts, medical staff is targeted, as was already alluded to, which causes, because of the extreme strain on the system, the local system, then you have regular individuals stepping up and trying to assist medically. You see, I saw a few videos from Gaza where you had a regular reporter sewing up very difficult wounds at the end of the day. And he is showing how he's progressing, and actually he's really good at sewing up wounds at this point, even facial scarring. So my question is there any post-conflict, or are you aware of any programs that you would integrate these individuals and maybe teach them the necessary skills? Because they're obviously, they have the heart of a doctor, so to speak, the soul of a healer. Are there any movements in that? So post-conflict, during conflict, I assume it's too difficult to train them properly, but perhaps post-conflict, anything in that direction? Thank you.
Will you hear an immediate response? Let's take a couple of questions, if that's okay. Any further observations? Dr. Petrič, if you would.
Yes, you are now in the country where we really, I believe, understand the potential of civil society in health. And in particular, the potential of young people in health. The Youth Health Organization, which is global, originates in this country. So just for you to know, we are a little bit extraordinary in many ways. Sport is our priority, our winners in Tour de France and elsewhere, but also this is very specific for these countries. Why this is so, I wouldn't know, but it would be a too long discussion. But exactly what I was saying before for women, that we need to explore the potential in women participating and being involved more, I'm saying the same for civil society organizations. There's so much goodwill there, but there is also mistrust to what they are doing, in particular by health professionals. So what we did in my country in this regard is that we developed in Public Health Institute a special unit that tries to mediate between the civil society in health and health professionals, so that they on a regular basis talk together and do something together, because doing something together is when trust comes. I really hate these post-conflict ideas. Why is that? Because I think we are in the conflicts now, so we will think of post-conflict when we get there, but still, you know, before we get there, so much can be done. And now I will go back to where we were before, Ukraine, for example. WHO there could not do all the work needed there if it won't be for civil society organizations, national and international, working hand in hand with those professionals there. And the role of WHO actually is coordinating, getting them all under the same guidelines, or agreeing on the guidelines and doing the work based on science. As you so rightly say, they are goodwill people, but maybe they want to do good, but it's not evidence-based, and we have to work together, professionals, scientists, experts, with the civil society. That is so powerful. Very recently, last year, in this country, we have great floods. So houses were, you know, run with the water, people were killed, and so on. So it was civil society that organized the rest of the people, volunteers and so on. Civil protection was in charge, but using a lot the potential of civil society. And also those organizations that, you know, are skilled in counseling people when they are in trouble, in mental health problems were there. You know, the house was gone, was a big stress to them. It's minor if we compare it with the war. But NGOs working in this area work together with civil protection, and civil protection work together also with health professionals, so we got it right. We got it right, but it was only because we were working together. As to the young people again, yes, you might not be a good speaker, but you know, the big words that we were listening and will be listening in such events don't change anything. What does change things is hard work on the ground in the community, and this was so nicely said, you know. So continue with your work and don't be frustrated if you cannot, you know, speak like I do, because I've been so much around. You know, it's a lot of words, but the real stuff is when you work in concrete situations and you try to do something really practical there.
Thank you once again. I think the most important thing is ensuring issues of inclusivity. We cannot run away from partnerships. We cannot run away from collaborations, because when you talk of the people who participate in these health-related interventions during conflict, the issue is how do we enhance their capacities even beyond the actual hot war maybe face. So this is where now we talk of building capacity and empowerment in what we call community-based healthcare workers, working together with the professional medical personnel, and also ensuring that the systems, healthcare systems at community level are linked to national healthcare systems in order to ensure integration. Another important yardstick is that when you look at the PCRD policy, the 2024 revised one, we have added new pillars, I think, which one is the issue of youth inclusion, because we realize that issues of innovation and technology is also critical. Hence, even in the health services, we need the brains and the minds of young people in how they can use technology even to disseminate and advocate for good and effective medicines, remedies, and even to refer people to the centers. Another pillar is the issue of environmental sustainability. We know that during conflict, there's a lot of migration and mobility. There's also issues of climate-induced disasters, so much that, like you are saying, the issue of cholera. During the war, these diseases, when they come, they are not being addressed adequately. Therefore, in post-conflict, how do we now ensure that the aftermath of these diseases are taken care of? Issues of women, peace and security in health sector, issues of negotiations, ensuring that women are not only active agents, but their voices are heard at high-level decision-making positions, because we normally say, I come from Lesotho, maybe I want to flag that, we normally say that women, they will know like specific centered approaches that are important to their own needs. For instance, if women who have been sexually abused during conflict, when they give birth, it is women who will be giving birth to other women during when there's no medical services. So how do we ensure that these women are well trained to ensure that the health services that they deliver also comply with human rights standards as well as health accredited standards to ensure that they don't multiply, diseases or risks. So these are some of the things to ensure that continued training, capacity building, empowerment. But I also want to flag the issue of health financing during post-conflict situation, because if we don't invest more finances, it will be difficult to ensure that the benefits go to the targeted people by right people. There are no solutions for women if women are not included. Thank you.
Thank you. Thank you so much for this. The question you raised and to which you responded also is fundamentally about trust. As you referred to, trust in skill set, protection of sectors, questions of credentials, all of these kinds of questions. But exactly as you described, the ability to sustain fora, an understanding of the added value, not replacement, but added value, especially in situations or countries where you don't have a prevalence of specialized healthcare services. The same community health workers responding to health emergencies are oftentimes the same who we would describe as quote-unquote peace builders, responding to conflicts that may arise. And that has everything to do with the integrity of the individuals and the place they enjoy within society to serve as a trusted, if you will, broker in advancement of the common good, in this case, health. We have a few minutes left. I want to see if there's any other question. If not, I'll turn for final reflections from our distinguished panelists. Any observations or questions that would wish to come out? Don't be shy. Fair enough. Mariana, we'll start with you. Any final reflections you would wish to share?
Final reflections. Probably, I agree totally with you, because we need to improve community networks, to improve health sector and conflict affect countries. And at the same time, we need to look better for specific diseases, like you said before, like reproductive health. And you need to create policies through inclusive lenses. And something that you said that I'm working in my organization is digital public infrastructure. And digital public infrastructure is something essential to improve healthcare in countries affected by conflicts. And at the same time, I love it that you said before about, oh, I don't like to think in post-conflict, because I'm from Latin America, and world look at us like we are not in a conflict, but we have urban conflicts, urban violence. A lot of humans in Brazil, for example, they don't have access to healthcare. They don't have access to support in terms of GBV, specifically in domestic violence. So we need to look to the peace like something so much bigger than peace and war. What is war? You are in a war all the time. So when I think in peace responsive policies, I think in look to the peace all the time, improve the peace all the time, build the policies with peace lenses all the time. And I think that's it. Thank you so much.
Thank you, Mariana, very clear. And particularly the recognition of the way in which conflicts are changing and experienced in differing ways, including on the prevalence of urban conflict, which is persistent and systemic in ways that are perhaps not as overtly war, but are experienced in the same way. Final observations, Frédéric, if you would.
Yeah, thank you. This was an extremely stimulating panel. It was great to hear all points of view. I want to offer a few words of hope, because we talk about extremely difficult situation, protracted conflict, multi-factorial violence, and targeted health workers. But there's a lot of hope. Because even in conflict zone, even in the most affected violent areas, you still have people who care, you still have people who have some leverage, you have people who can bargain, and people who can leverage their access, their understanding of the situation, and make the situation better. But for that, we might need to look at a change on the way we're thinking, health as infrastructure, and eradicating some type of disease, and peace as trying to broker a ceasefire somewhere between belligerents. I think we need to stop thinking like this. We need to be integrated. We need to be comprehensive. We need to be flexible, and we need to listen to the communities, because I think this is where the key stands. You know, the progress we make, our ability to solve issues is not necessarily at the highest level. I'm not going to say that diplomacy is useless, it is not. But if we wait until we have the perfect health system, we have perfect infrastructure, we have perfect peace to start working, it will never happen. So we need to find solution at every level possible, and be flexible, be responsive, including in fundraising, including in targeting issues that can show an example and that we can capitalize on to build a better system for everyone. So I just want to say that if we do that, and I know we can do it, we have lots of examples where we've been doing it, there's lots of hope.
Thank you for this, Frédéric. And what you allude to as well is being clear about what we mean by peace. And there's an articulation of this as not merely the absence of war, but the very conditions that enable societies to envision a future they want, which necessarily includes dignified access to health and work and education. This is the sustaining peace agenda, which cannot be neglected in the midst of heightened global tensions. Please, if you would, Madam Executive Secretary, the final reflection.
Okay. From me, I think the final word is the issue of the health-peace nexus during post-conflict setup. Because you find that, like I said, that normally there's a thin line in terms of where do we draw the end of peace and the start of post-conflict. The reason I'm saying is that when you look at the health peace nexus, we are talking about triple actions: the humanitarian action, the development action, as well as the peace action. And we need to ensure that at all costs, there's these interlinkages between the three nexuses in order to ensure that lives of citizens affected by conflict are healthy as well as peaceful. I like the idea when you said that all the time we need to talk about peace. And to conclude from what Dr. Tedros said, there is no health without peace and no peace without health. So this should be our everyday talk and conversation in post-conflict setup. Thank you.
Thank you so much. A final word for all of us, given to Dr. Petrič. We've reflected on promoting peace-responsive health interventions. Over to you for a concluding remark.
Thank you very much. I think somehow obliged to say something on Yemen before I say my concluding words, and it's because listening to my colleague here speaking of those countries that are in conflict for a long time, and they are in Africa too, and there are areas in Africa, like Nuba population is suffering from leprosy, disease that should not be existing in the world anymore. What do we do there? And you are right, it's difficult because, you know, international organizations, the UN organizations, don't enter these kind of areas. But there is a solution, actually. Who does enter these kind of areas are NGOs. These are Medical Doctors Sans Frontiers. These are Red Cross and other organizations that do enter, Red Cross maybe not, but the other NGOs that do enter these kind of areas. So what could we do as countries organized within WHO? We could support better those organizations that dare to go there and do the work. And this is exactly what could be done in Yemen. Maybe UN cannot enter, or I don't know who cannot enter, but the NGOs do enter anyway. So why not listen to them and support them in doing so? So this is so important, and for this, Slovenia, together with Thailand, this year at World Health Assembly, struggled to consensually adopt the resolution on social participation. Mm-hmm. It is exactly about health sector working together with NGOs that work in the health area and combine forces and do something good where we, health sector, can really not do it for different reasons. And I hope this resolution will be implemented. As I sit here, I'll do everything, you know, that we will go into implementation, because resolutions and all this we adopt all the time doesn't change anything. I'm repeating this. What does change is if you get them implemented. We didn't do well with SDGs, universal health coverage, and so on. So we should think better who has the potential to help us governments to really perform, not just talk.
Thank you so much, and a word of appreciation again to our distinguished panelists. Thank you.